Body to tonight's presentation on molecular testing and its implications for the adjuvant management of early stage non-small cell lung cancer. We're going to go ahead and review some of the recent data on immunotherapy in early stage disease, and then talk a little bit about the logistics of coordinating tissue processing and ensuring people get access to appropriate care. And with that, I think I'll turn it over to Charu and let you begin.
John and I thought it would be really nice to present some of the recent data in regards to a couple of different approvals that have come about for adjuvant therapy for early stage lung cancer. We thought we would talk about a proposed mechanism or a proposed process for molecular testing at Penn. I'm a thoracic oncologist. I know almost everyone on the call here. So thank you for joining us, and we'll get started. And I think at the end, we'll have cases. So this is just meant to be about 20 to 30 minutes of slides and discussion, and then we'll turn it over to cases. So over the past 10 to 15 years, it's been a really fun joyride. Targeted therapy and immunotherapy have meaningfully improved survival in stage 4 non-small cell lung cancer. I thought this slide was really well put together. This is from a presentation at this year's ASCO annual meeting by Zosia Petroska, where she outlined some of the survival curves dating back to 20 years ago in 2002, where we looked at survival from 4 different chemotherapy drug regimens incorporating a platinum doublet chemotherapy. And at that time, stage 4 lung cancer median overall survival was only in the order of 8 months. Fast forward to 2010s, where we started to use TKIs as well as EGFR TKIs. And now with the use of drugs such as alectinib, we are able to obtain a 5-year overall survival for alectinib at 62.5%, which is amazing for stage 4 non-small cell lung cancer. And this is data derived from the recent 5-year follow-up from the ALEX trial that demonstrated superiority compared to chemo. And then immunotherapy, which really has been heralded within the last 10 years, has doubled survival in patients that are, close to doubled survival in patients that may not have an activating mutation. So on the far right, you'll see survival with pembrolizumab, which is on the top, compared to chemotherapy in patients that have high PD-L1 or PD-L1 greater than 50% expression. You'll see median overall survival there, about 43% at 36 months, with a 5-year survival rate of 32%. Amazing results with the use of targeted therapy as well as immunotherapy. So definitely the next question, or naturally the next question, is can we extend these survival benefits to the early stage setting, similar to what we've seen in the stage 4 setting? In the early stage setting, adjuvant chemotherapy provides an overall survival benefit, and this is data dating back to the late 90s, early 2000s. Meta-analyses have demonstrated a disease-free survival improvement with a hazard ratio of 0.84. Overall survival advantage is there, but the hazard ratio is only about 0.9. And if we look at the 5-year, 10-year improvement, the improvement is only about 4 to 5%. There are several different factors to consider in the decision-making process for adjuvant therapy. I think the stakes are a little bit higher. We have to obviously look at the drug and the mechanism of action. We have to look at safety of the agent, potential of harm, magnitude of clinical benefit. I think this is a much higher bar because it's in the adjuvant setting. We have to think about the potential for harm, as everyone's aware. And then issues such as cost to society, cost to the patient, overall health-related costs, what is the feasibility? And finally, do we have a biomarker to guide this treatment? And this is important because of a couple of approvals that have come through, which I've highlighted here. So the first one, in December of 2020, FDA approved osimertinib for adjuvant therapy after surgery in patients with lung cancer whose tumors have EGFR, either exon 19 deletion or exon 21 L858R mutations. It's a very tight indication, very tight approval. It's only for these 2 activating mutations, and they have to be determined by an FDA approved test. And then most recently, on October 15, 2021, FDA approved atezolizumab for adjuvant treatment following resection and platinum-based chemotherapy in patients with stage 2 to 3A non-small cell lung cancer whose tumors have a PD-L1 expression of greater than equal to 1%, again, as determined by an FDA-approved test. It's important to remember that this is verbatim from the FDA approval. They do indicate that these patients should get platinum-based chemotherapy. They specify the stage, and most importantly, they specify these patients have to have PD-L1 positivity. You will see that they are silent on the type of FDA test. In the medical oncology world, we sometimes really wrap ourselves up in which testing was performed for which particular drug. All these PD-L1 assays have been different. For example, atezolizumab has a completely different assay compared to what we use at HUP for PD-L1 expression, which was based on the Merck PD-L1 assay. However, the FDA is silent because these assays are largely interchangeable. So I thought we could just review some of the study design and nuances. I'll start with the atezolizumab because it's slightly more recent. So this was the Empower 010 study design. Started with completely resected stage 1B to 3A patients. This was per the AJCC version 7. It's slightly changed in AJCC 8. Stage 1B tumors that were greater than equal to 4 centimeter with a good performance status after surgery were included, irrespective of PD-L1 analysis. All the patients needed to have 1 to 4 cycles of chemotherapy with a platinum doublet, cisplatin partner. And then 1,280 patients were randomized to either receive atezolizumab every 3 weeks for a year or best supportive care. And we ended up with 1,005 randomized patients. There was no crossover allowed. You can see the stratification factors, primary endpoints, and key secondary endpoints listed here. And then these were tested in a hierarchical fashion. First, the primary endpoint was disease-free survival in PD-L1 positive patients in stage 2 to 3A. And you'll remember that this is the approval, basically based on this primary DFS. And then if positive, they would do a DFS in all randomized patients for stage 2 to 3A. And if that was positive, then they would do the DFS in intent to treat, which included the stage 1B. And then if only that was positive, they would go and do a overall survival. And then you'll see here that at the time of this report, endpoint was met at DFS interim analysis for the first two sort of primary endpoints, which were PD-L1 positive as well as the randomized population. So here are the results. So firstly, if we look at disease-free survival in the population of interest, PD-L1 positive stage 2 to 3A, you can see there is an improvement in DFS. Hazard ratio here is about 0.66. P-value is significant. The median disease-free survival has not really reached for patients that received atezolizumab. Moving on to the center of the slide, we'll see all randomized stage 2 to 3A population stratified hazard ratio. Again, this is including PD-L1 negative patients is 0.79. So we are starting to see a smaller difference. Maybe there's a difference, but much smaller. And then when we include the 1Bs, the curves are very, very similar to each other. And the hazard ratio here is only 0.81. And the p-value is significant, but it's it's 0.04. And here are some of the key, I think, clinical characteristics that we think about when we look at patients or the subgroups that included EGFR and ALK. And again, I have to mention that this trial did include EGFR and ALK, albeit small number of patients. You can see that as the expression of PD-L1 increases, the DFS advantage increases. So if we were to include everyone up on top, you can see that the DFS for TC50 or PD-L1 greater than 50% is 0.43. And overall, we do see an advantage also for the 1 to 49%. I think this difference is a little bit more stark when you look at the subgroup excluding EGFR and ALK, which is at the bottom. Here you'll see for PD-L1 greater than equal to 50%, we think that the intervals are getting a slightly probably a little bit tighter. They're not crossing one as much as they did, and the hazard ratio is still 0.43. Again, these are subgroup analyses. These were not pre-specified, but I think it's important to really see that the difference or the improvement may be related to PD-L1 status. And here's the immature data from overall survival. You can see hazard ratios of 0.77 for the primary population of interest. And then the curves are basically overlapping for all randomized as well as the intent to treat. In fact, if we include the stage 1Bs, the hazard ratio is 1.07. So there is potentially some harm. This was, again, not formally tested, and we'll just have to wait. So my sort of conclusions here are, this is the first phase 3 study of immunotherapy in the adjuvant setting to show a disease-free survival benefit. Benefit was seen in PD-L1 positive, but much more pronounced in PD-L1 greater than 50%. And I think something to consider it in patients with no actionable mutations, if we've tested them and appropriately sure that we don't have an actionable marker, patients that are heavy smokers or former smokers, and high PD-L1. And again, I think this is going to be a matter of shared decision-making. So this has been approved now, and I put the indication right under it, and we've discussed this, but it's also important to know that we just recently saw another press release. So not far behind, Keytruda or pembrolizumab has also showed a statistically significant improvement in disease-free survival versus placebo as adjuvant treatment for patients with stage 1B to 3A lung cancer, regardless of PD-L1 expression. Now, this is from the press release. We don't know any of the data yet. I think we'll have to see what the benefit is in PD-L1 negative, and really are the 1Bs really deriving benefit. I think we'll just have to see, wait and see. The second trial is the Audora trial. So 1 year ago, actually a year and a half ago, in summer of 2020, we heard results from the Audora phase 3 double-blind study design. Very similar patient population, stage 1B to 3A. However, the difference here is that these patients could have come into this trial without receiving adjuvant chemotherapy. These patients had to have one of these 2 mutations, and they received either osimertinib 80 milligrams once daily for 3 years or placebo daily. And then they were followed. And on the right, you see the disease-free survival. I mean, these are curves that are very clearly separated. And we've never quite seen a hazard ratio of 0.17 with the use of an adjuvant therapy, at least in the lung cancer space. This is not overall survival, this is disease-free survival, but significant benefit. And based on this, I think, degree of benefit for DFS, the FDA decided to approve it. Again, detected mutations by an FDA approved test. They remain silent on which test is used. So this has been approved. So what is the role for molecular testing? So given the availability of targeted agents as well as immunotherapy, I think it's very important to test. Some of the challenges that we have are, we have very robust reflex testing pathways in place at Penn. Testing for early stage resected non-small cell lung cancer actually doesn't always occur uniformly. There is a 14-day rule regarding NGS testing, and that's one of the things that has sometimes prevented us from ordering molecular testing in somebody who John or Doreen may operate on, that they have to come for their first post-operative visit to actually initiate testing. And then medical oncologists do sort of take ownership of ensuring completeness in stage 4 disease, but not all patients with early stage lung cancer are seen by medical oncology, but I'm going to turn it over to John in just a minute after I finish these slides so that we can talk about that process. One of the things that I thought I would pull up is some of the current guidelines for molecular testing in patients with lung cancer. And we recently published this looking at how heterogeneous the recommendations are, recognizing that some of these recommendations are dated 2017 and 2018. But if we focus on NCCN guidelines, which are right at the top, you'll see 2021. Again, this predates the atezolizumab approval, but for stage 1B to 3A disease, they are recommending to test for at least EGFR mutation on diagnostic biopsy or surgical resection sample, and they say what adjuvant treatment should be administered. Again, the CAP ISLAC AMP guidelines are a little bit old, 2018, ASCO's 2017. But if you look at the Canadian consensus recommendation, which is from 2020, they do recommend comprehensive reflex biomarker testing recommended for all patients, regardless of disease stage. So I think this is important that it's not just us, but also our neighbors across the border are thinking about this. And also, I think if we look across populations that may have high rates of EGFR mutation, if you look at the Asian Thoracic Oncology Research Group, they recommend molecular testing. Chinese guidelines recommend EGFR mutation testing. Indian guidelines recommend EGFR and ALK-ROS, and then Society of Translational Medicine consensus as far back as 2019 did say that routine detection of EGFR mutation in surgically resected non-squamous non-small cell lung cancer is recommended. Here is a recommended framework or sort of a workflow that we think may be actually very helpful for not just our institution, but other institutions. If a patient presents with clinically stage 1 to 3 non-squamous non-small cell lung cancer, and if they have a biopsy and cytology, at our center, we do reflex testing that's ordered by the pathologist, and we usually run the full panel, including PD-L1 testing, and the report is available. However, this can be either tumor resected or not resected, but what we are trying to do is that if the tumor is resected, we can also try to get molecular testing performed so that it's not just reflexively performed on the cytology sample, but it can be performed on the surgical sample. And then if their biopsy is not adequate, then they can either be done on the tumor resection sample, or in certain cases, a rebiopsy can be performed, for example, if a patient is undergoing concurrent chemoradiation therapy. So this is one other paradigm that can be adopted by institutions. And the final thing that we are working on at Penn is this development of an EMR-based nudge, which will prompt physicians to place orders, or actually make it easy for physicians to order molecular testing. This nudge, which will be electronic medical record based, will fire at the time of the first post-operative visit, at the time when John or Dorade are seeing a patient for the first time. And then this will basically go to the pathology department, where the tissue coordinator can check if NGS was already in process on the biopsy sample or on the cytology sample. If it's not, they will pull the surgical resection tissue for next generation sequencing, with the idea that results may be available in time for medical oncology consultation. So this is sort of one of the next efforts that we are going to be launching at Penn in terms of improving molecular testing. But I wanted to just turn this over to John to talk about your recent changes in terms of management, molecular testing, as well as referrals.
Thanks, True. That was a great overview. I think that, as a surgeon, there's very little I can show you in terms of surgical studies or things that we've done, as this is really mostly focused on medical oncology. But I can tell you that we certainly have had a shift in our practice patterns. And I liked your first slide, True, because you kind of pointed out, what we did in the early 2000s and then kind of the mid 2000s and our current practice now. And, traditionally, the early stage lung cancers have been the purview of the surgeons. We would both diagnose them, we would treat them, and then we'd follow them in surveillance. And a lot of that predated 2000 because really, if you think about it, at that time, radiation therapy for lung cancers was based on the port analysis, which suggested that actually radiation therapy was not only not beneficial, but actually was detrimental. And a lot of the data for adjuvant platinum-based chemotherapy, postoperative adjuvant platinum-based chemotherapy hadn't come out of Europe yet. So it's really about the early 2000s when we kind of even got medical oncologists involved with the care of these early stage patients. But certainly, over the past 20 years, we've had a major change. And I think you described when we really started to do some molecular testing in 2010 to 14. And there's lots of studies that show just testing people actually improved their outcome. Well, why was that? It was because you were getting those low-hanging fruit and identifying those people early on that if they had a recurrence, you potentially would have something to come back with. And then you go into the current era where it seems like we have a new approval every few months. We may further refine some of our testing to different exons, different variations in a particular area that we're looking at. Then we have immunotherapy coming online. So from a surgical perspective, it really is no longer, even early stage disease is really no longer a disease for surgeons. It's really a disease for a team of thoracic oncologists. And so I think, I see Matt Poots is on the line, Durade is on the line, surgeons that I know. And I think certainly if you look at our practice, it has evolved over the last 10 years actually, but probably small amounts over 20 years where we really approach these people as a team. It's impossible for me as a surgeon to really keep up with the nuances of molecular testing to try to argue with whether the Keytruda test for PD-L1 is appropriate or not. And yet I have a lot of folks around me who know a lot about those tests, both from a laboratory medicine standpoint and also from medical oncology background that can help us put this data together and to get it in a package so that we can deliver it to the right patient at the right time. Obviously, as we think about some of the impacts that have been made with molecular therapies, with immunotherapies in the stage 4, it just begs the question, why can't we move some of those treatments into the earlier stages? And obviously, it's taken a little bit longer to get those studies designed and to get some of those studies accomplished, but we are making some headway. Drew and I, about a year ago, I think, were on a conference call with some surgeons, local surgeons, Philadelphia and greater area. And we were talking about the Audora trial when it came out. And the reality is very few of the surgeons on the call had heard about it. And so I think the first thing I would say is the kind of supporting discussion of postoperative patients at your multidisciplinary boards is equally as important as discussing them preoperatively or pre-treatment to decide which direction you're going to go into.
And I have one quick question. You have the sort of a 3-phase approach. You've got your reflex testing, your EMR nudge, and your tissue coordinator. Who is your tissue coordinator and how are they intervening in the process?
So tissue coordinators are a godsend, Charles. So basically, these are individuals that are physically housed within pathology. They are employed by the Department of Pathology, but they serve as the liaison between medical oncologists and an interdisciplinary team and pathologists. So what they do is, let's say if I see a patient with stage 4 lung cancer, and I'm giving you an example of stage 4 lung cancer, and if it's an outside case, we usually get slides over, we'll usually get the block or cytology samples, the block over to initiate testing. And what the tissue coordinator is really doing is figuring out if this patient has had testing done outside, whether or not we have block available, whether or not testing has been initiated, where in the process is the testing, and when I will get the results. So all I have to do, or Roger has to do, is email this tissue coordinator pool and say, hey, by the way, where is PD-L1 and EGFR results for Mr. XYZ, and they help do some of the legwork. For our internal cases, they're also very good because they are the ones who pull out all the specimens for these reflex testing pathways. So for example, If Jeff Thompson, who's one of our pulmonologists, does a bronch, gets a biopsy sample, the molecular checkbox is ticked. The tissue coordinator is the one who will then take the samples over and move them over to the molecular pathology lab and say this person is now in queue for DNA sequencing and RNA fusion panel. So that's where they sort of sit and coordinate all of these roles.
And something else that they do, which borders on magical, but it's almost like there's a secret society of molecular test results. And because there are all these vendors doing these tests, especially on referral cases, they have a unique ability to actually find these results. So when I order CPD, for example, and they say, well, no, it's actually been done already. Here are the Caris results. Here are the neogenomics. Here are the Foundation One results. So they are highly knowledgeable at navigating what is by any measure a ridiculously complex matrix of molecular testing facilities. And they're very consistent in being able to find these results, which I can't find in Epic or anywhere else. They haven't actually told me what the secret sauce is, but they're very consistent in finding these, and it's enormously helpful.
Yeah, and I would
one
say
thing they also do is, one thing they also do is, if a patient had their testing done in 2019 and I'm seeing them having metastatic recurrence in 2022, and I go ahead and order it, they will say, oh, by the way, Dr. Agrawal, this was already done in 2019 and here's the results. In-house testing as well. So they're very good. Sorry, John, go ahead.
Oh, no, I was just going to say, if you remember back, Drew and Roger, we had a lot of discussion about this in our service line meetings, and a lot of the concept of the tissue coordinator actually grew out of the thoracic oncology group, because we were as we expanded, we really exploded with our molecular testing compared to other cancers. And it got complicated because there were multiple different places to try to find it. And so this eventually ended up being kind of a negotiated position between the health system and the clinicians and the pathology department. And now they have quite a few of them. And if one goes out or they change over, we really notice it. It has become a very, very integral part of providing efficient care. You can do it without them, but it's an awful lot of work that somebody has to put in to try to manage the blocks and to manage the disparate systems that report back on what the information is. And I don't know, Drew, if you want to comment too, we're working on a tab in Epic where you could kind of click and find all of their molecular genetic testing. I don't know where we are on that. I think that's still kind of in development, but it's a work in progress.
So I think it's live. The Precision Medicine tab does house our DNA and RNA sequencing results. It doesn't quite house the PD-L1 testing, which is, quite challenging to find in its current form. Roger can correct me, but I find it hidden and under several different layers. It's almost like it's secret and you're not supposed to find it. So we are working on ways to make it clearly accessible, but DNA sequencing results are easier to find than most other things in Epic, I think.
The utility infielder of the path department.
Sorry, say that again,
I
Charles.
was to say the tissue coordinator is the utility infielder of the path department.
Yeah, correct.
Yes.
And vitally important. And I think somewhat unique to our, I don't know how many pathology groups have them, but I think everybody should have at least one. And as we evolve in the future, that's going to be a vital position.
Oh, it sounds like an excellent resource.
And it was a heavy lift to get them initially, because we were inventing a position that had never been done before. And the concept from upper management is, okay, explain to us what these people are going to do and how they're going to be paid for. And they are remarkably useful. So
well,
I hope others can leverage that experience.
And by the way, the folks that were asking for the data are now very happy because of the amount of revenue they capture off of the molecular therapies and immunotherapies that are given to the advanced stage patients. So I haven't looked at the finances of those positions in a while, since the first time we kind of were pushing it. But it's a good investment.
Yeah, I'd be shocked
better
if
than
they didn't
Bitcoin.
financially justify their existence.
Yeah, it's better than Bitcoin. It's exploded 10,000%.